Good morning, all of you. Uh, I thank the BOS for giving me an opportunity to share a few tips and tricks in K-wiring of the distal radius. I think K-wiring and distal radius, we know that since our orthopedic nursery. And I would say that all of you, all of the people who are present in this hall are experts in K-wiring of the distal radius fractures. So I'll just share a few of my thoughts. I think all of us, by the time we start practice, we will all have fixed ideas about treating distal radius fractures, especially with K-wires. And if I can contribute to some updating your skills or knowledge, I would be very happy. My indication for treating for using KYC in a distal radius fracture, I think only 2 or 3 indications are there. One, definitely an extra-articular fracture where the dorsal comminution and dorsal displacement is not that excessive. So in these cases, I would opt for I would think of using a K-wire for a distal radius fracture. One must remember that K-wires on their own cannot achieve reduction. Reduction has to be achieved by closed or open means, and K-wire just is an internal splint which helps to maintain the reduction. K-wire cannot achieve the reduction. I would strongly suggest that one would take a limited incision, identify the nerve, especially on the radial styloid, identify the superficial branch of radial nerve and the extensor compartment, the first extensor compartment tendons. Make sure that they are out of harm's way and insert the K-wire. Even while inserting K-wires from the dorsum, I would state that you should see the extensor tendon. If you are going very close to the EPL tendon, lateralize it, take a bigger incision so that that tendon does not give a problem. And then only insert a K-wire like this. Cutting the K-wire, I would, especially on the dorsum, bending it becomes dicey. So if you bend it on this way, it affects the lateral tendons. If you bend it this way, it may affect the middle tendon. So my preference is to cut the K-wire under the skin, above the tendon. Of course, everybody is free to have his own ideas and practice. So I prefer to use 1.5 millimeter K-wires inserted from the radial styloid. I prefer not to use K-wires from the medial side. If necessary, you can go between the 4th and 5th compartment. The wires, I prefer to cut them close to the bone and bend them, especially on the radial styloid, so that even the K-wires can give a buttress on the radial styloid. In this example, I would urge not to keep the K-wires so long, just slightly coming out of the medial cortex. Most important in the close reduction method for distal radius is to have a perfect reduction of the volar cortex that gives very good stability to the fracture. One more thing, always supplement the K-wire fixation, because irrespective of whatever we see on the X-ray, always supplement it with a plaster. The plaster, especially if the fracture is dorsally displaced and comminuted, always give the plaster with slight volar flexion. I prefer to give a above elbow slab for few days in supination and encourage the patient to start moving the fingers and the shoulder right from the first day. That prevents shoulder hand syndrome and stiffness and morbidity and unpleasantness in the post-operative period. This is the same example where the wires have been eventually removed, and that's the function at 1 year. Another example or another indication is probably dorsal rim or dorsal shear fractures, where you can see that, or where you can judge that articular surface is mostly intact, not too much, not too badly comminuted. So in these cases, where it looks like a dislocation, but it is really not a dislocation, it's a dorsal shear fracture. So here, again, close reduction. Keep all the other implants ready, all the other tools. But here, basically, close reduction under anesthesia will give you a reduction. And then just you have to maintain it with K-wires. Here, the diameter of the K wire is not important. Placement of the K wires is important. I prefer not to use more than 1.5. In this case, I have used only 1 millimeter K wires. You can see that there is a dorsal plaster slab which helps to keep the wrist flexed and prevents, or I would say, gives an additional support to the K wires to prevent it from displacing further. That is the, you can see a perfect reduction of the volar cortex and perfect healing in this case. Remember one thing, K-wires per se on their own is not a guarantee that the fracture will not collapse. The dorsal comminution, the placement of the K-wires, you have to always be wary of collapse of a distal radius fracture. So in spite of a good reduction, especially if the volar cortex is not perfectly reduced, a collapse is seen. In this case, you can see that there is a initial plaster which is given after K-wires, but in spite of that, the fractures has collapsed, and this will lead to a positive ulnar variance, restricted distal radioulnar joint movements, restricted or painful forearm rotations, and the patient will not be happy. Another thing which I would not advise is cutting the K-wires outside, especially in our circumstances where there is a likelihood of pain and spin tract infections. So I would like to, I personally prefer to bury the K-wires under the skin in such cases. I would not recommend K-wires being put in this manner. One would like to identify the fracture anatomy. This probably is not a case for K-wiring at all. In current circumstances, I would use a plate in this, and even this configuration of K-wires is not recommended. So though it's one should not, I would say, extend the indications of surgical democracy in India. Thank you. Can I extend for 1 minute? One more indication of K-wires is in the pediatric age group where there is I would say, open epiphysis, especially in such small children where you cannot get a close reduction or your reduction is slipping or patient presents late. So you may open it. Now there is you can probably put K-wires from the retrograde manner. Probably you are sparing the epiphysis, probably you have taken all care. But I prefer to insert the K-wires from the mid shaft of the radius and ulna in such cases. This is 3 weeks post-op. This is 6 weeks post-op. And the fracture completely heals. This is the epiphysis sparing method. And I would, probably this is a thing which I would recommend. Another case which was treated by open reduction. This is immediate post-op. This is 1 year post-op. And this is 8 years post-op after removal of K-wires. You can see that there is no growth disturbance. The fracture is healed perfectly. Another indication of K-wires is the use of K-wires for external fixator, but you must always ensure that there is an additional support for the distal radius, because external fixator per se does not give you a good reduction of the fracture. In such cases, this is not done by me. I've just used it as an example. So we have used K-wires here to augment the reduction. The external fixator just supports it, and that is how it heals. The function is a different matter altogether in this case. So most important thing while you are treating a distal radius fractures is to restore the distal radioulnar joint to get a painless rotation of the forearm. Of course, restoration of the radiocarpal joint to get good flexion extension. And one must always aim for painless and complete shoulder and hand range of motion. Thank you for your attention.